Welcome back to the Doc Talk podcast. I'm Dr. Sheila Wijayasinghe.
And I'm Dr. Shazma Mathani. So today we're diving into episodes 10 and 11 of The Pitt, which cover 4 p.m. and 5 p.m. of this shift. Somehow this day just keeps getting worse and worse for everyone in the department. Like, I don't know how much worse it can get, to be totally honest, but it just keeps getting worse.
And it really blends in all the different cases of burns to the stroke to workplace violence and a delivery that goes sideways before anyone can even put gloves on.
And so because that delivery is a delivery and because shoulder dystocia is one of those truly high stakes obstetrical emergencies, we actually brought in someone who knows and does this for a living.
So we are so excited to be able to share with you that we have a wonderful special guest with us for the first case of the episode, and somebody that you probably already follow on Instagram or TikTok. Shaz and I are huge fans of our next guest.
So she's an OB-GYN practicing in the U.S. She's a massive social media following and is known for being brilliantly clear, evidence-based, and just fun to learn from. Please welcome Dr. Fran, aka Paging Dr. Fran.
Thank you so much for having me. I'm so excited to be here. That was such a kind introduction. Thank you.
Okay, awesome. So we're so excited to have you here. So when Sheila and I usually watch these episodes that we can do these podcast episodes on them, we often are frantically taking notes, or I'm sitting with the laptop in front of my TV and taking notes. And so for this one, because we knew that you were going to come and chat with us about it, I have so many questions about this shoulder dystocia case. But let's just set the scene to get our listeners up to speed and then dig into chatting with you about it.
Perfect.
So we are seeing a actively laboring patient come in who's showing up crowning. So she's in the process of delivering this baby. And I used to do deliveries years ago, stopped because of these moments. And it was such a frantic moment. So can you tell us, what did you think when you saw this?
I mean, it's not uncommon for us to have patients basically be crowning down in the emergency department. A lot of the times the ED is where patients show up for a birth. If they're not actively crowning, they're typically taken upstairs to labor and delivery to us. But it's not uncommon that we have a code OB call to the ED and we go run down there and see what's going on. And that is kind of what happened in this episode. They did call OB eventually.
Eventually.
So I'm glad that you said that, because I'm an emergency doctor, so I work in the emerge, and that part stood out to me. So yes, every laboring patient presents to triage, and there's a porter that then takes them upstairs to L&D. Unless they're crowning, right? And so there have been situations where there have been babies that have been delivered in the ER. I'm at an obstetrical site, so we always call for OB. But the one piece that stood out is that OB came and was yeah, you have this under control, and then left. That doesn't happen. That doesn't happen in real life.
It does not happen. Listen, my dad is an emergency room doc.
Oh, okay.
Retired now. But he told me, he's do not go into OB. That is the worst specialty. You should never want to do that, because he hated laboring moms in the ED. That's not the place for them. And so in my day-to-day life, when I do get called to the ED, as soon as I walk in, you can see that pressure lift off of the emergency room doc. They're thank God. Here you go. Please
someone who
take
knows what
over.
They're doing is here.
Right? Someone who does this more than me is taking this away from me. Thank God. And I thought really that was the first thing that stood out to me in this episode, was that they're we got it. We're good. And it's that. I know that from the emergency room side, my emergency medicine friends love this show because it is so hyper realistic in your day-to-day, minute-to-minute lives, that has stood out so much to them as being unrealistic to real life and real medicine.
Yeah. And the shoulder dystocia piece too. Can you walk us through a little bit about what shoulder dystocia is and what you do in that situation?
Yeah. So a shoulder dystocia is when the fetus's shoulders are getting stuck under the pubic bone. They're really supposed to come out, rotate, and come out, right? So what we see and what you saw in the episode is that turtle sign. So the head comes out and just turtles. Its little neck is just like this, and then it goes back under and nothing's happening. And that's our first sign that a shoulder dystocia is happening. And that's when we get all hands on deck, right? We call a shoulder dystocia. We do our first couple maneuvers. The first one, very important, is that the patient is laying back and we get her legs up. In the Pitt, I guess we did not consult any obstetricians because this patient continued to basically sit straight up. And then they started doing the maneuvers, which are just not going to work with opening up the pelvis and getting room to deliver that baby. So again, another maybe to most lay people would not be something that people notice, but as anyone who has delivered babies can attest, like that was a very strange setup for the delivery. I think the next steps that they did, so we have several maneuvers that we use to then deliver the baby. We put the legs back in McRoberts. We do suprapubic pressure where we basically can see the direction that the baby is supposed to turn, and we kind of help them on the outside, like rotate them down. So we do that. And if that doesn't work, then we have several other maneuvers where we either grab our hands in and grab their posterior arm and pull it out to help rotate them. We can do rotational maneuvers. So I thought that part was handled very well. But again, if an obstetrician was standing there, they would have been the one to step in to do it. I, in my real life, have a hard enough time trying to let my residents have those moments of doing it, much less someone who's not very much trained in shoulder dystocia management.
Yeah, so I'm glad that you said that, because that part stood out to me as well. That like that is not, I mean, like when I studied for my Royal College exam, like, yeah, I know like all the steps that you just said, like, yep, I know all those things. And I guess if you work at a site where there is an obstetrical backup, like you would have to know those things and be able to use those maneuvers in a pinch. But they literally had an obstetrician come down and then just be like,
she left. Looks like you got it. You got it.
See
you later.
She's like, see you later. You're good. Would in real life, again, we would stay there. We would deliver the placenta. Even if the baby had, if the emergency medicine doc had delivered the baby because we didn't make it in time, we would have still taken over and delivered the placenta. We would have done all the massage, all the things that are so day to day in our life. So it was, again, bizarre that the OB was like, I gotta go, see you later. And then they were left to manage the second, traumatic part of that delivery, which was the postpartum hemorrhage.
Yeah. So, I mean, like so can you take our listeners through, so we talked about the shoulder dystocia. Can you take our listeners through kind of what a postpartum hemorrhage is, how common it is, and like what the risk factors for it are?
Yeah, so postpartum hemorrhage happens in about 10% of deliveries. There are many causes for it. 70% of the time, it's from what we call uterine atony. Basically, the uterus muscle isn't contracting down on those spiral arteries to stop the bleeding. It just stays like floppy. And we can feel that when we're doing our massage. We can like feel a floppy uterus. So there's a couple of steps that we can do. We can do a bimanual massage where we're really encouraging that muscle to work. And that does work a lot of the times. We can give medications. And they did all of this on the show. Which again, impressive. I had no problems with the actual medicine that they practiced on the show for this part. That was all correct. But again, it would have been an obstetrician handling it versus the poor ED doc. So those are the typical things. We do know of risk factors for postpartum hemorrhages. So if you've had a postpartum hemorrhage in the past, that's a big indicator for us. If you have a fibroid uterus, if you have low hemoglobin, we're going to pay extra close attention to you because you don't have as much bandwidth to lose blood. If you have twins, if you have polyhydramnios, if you have anything that's distending your uterus more than like the average, that's going to make that uterus tired. It has to contract even more. Those are all risk factors for having a postpartum hemorrhage. I think in this situation, I don't recall any real risk factors other than maybe like a precipitous labor, which does contribute to that as well. Right. But they didn't give any details like, did you have a fibroid uterus or any of those things? But that happens a lot of times. The hemorrhages happen in patients we don't expect it to.
Right. Just being ready for it.
Yeah. And because they went all the way down the algorithm, like just shy of a hysterectomy of using the Bacry balloon. How often do you use those in real life?
So we have two devices. We have the Bacry balloon and we have the Jada vacuum tool. So they basically they do the opposite, actually. The Bacry balloon fills up with pressure. It puts pressure on those spiral arteries versus the Jada, which pulls the uterus down. I would say it's actually encouraged to use those fairly on in a hemorrhage because what you're really trying to do is prevent further blood loss. I would say I use one maybe like every second hemorrhage because we do try to use it earlier because we're trying to prevent more blood loss. Yeah.
Oh, interesting. Things have changed since I used to do deliveries. This is really fascinating.
Yeah. Now that we have more devices available, it really is encouraged to use it earlier on to prevent having to use more medications that aren't working or to prevent that further blood loss.
Oh, that's great to know. One important issue that we like to address a lot of times in our podcast is around equity. And in Canada, which we know is mirrored in the US as well, is access to prenatal care for Black women. We've seen a lot of things online lately around Black women being dismissed during their laboring process, that pain management is very different, and higher risk for pregnancy-related complications and mortality in Black women compared to their white counterparts. Any thoughts on this and how we as healthcare providers can ensure that we're aware of our biases and address anti-Black racism to ensure equitable outcomes for our patients?
I mean, this is obviously a huge problem in the field of obstetrics and gynecology. Really, our history is based off of the abuse of Black women, right? And it hasn't gotten much better since then. I think the really important continued conversation around that is super vital for people in training to be aware, to really address their own bias, to really hear these stories of Black women and what they've gone through. I think it's really important that we as physicians make our patients aware of that we are seeing them as Black women and that we are going to try to keep them safe in every way that we possibly can, from the beginning of prenatal care to make sure that they get their ultrasounds early, to make sure that we start a low-dose aspirin, to really taking their concerns seriously throughout the second and third trimester when they're having concerns. I know we've probably all seen the several different videos in the last week about Black women in labor who were recorded not getting the care that they deserved, whether that was in triage, actively basically delivering without a single person helping them. I think, in my places I've worked, that patient wouldn't have even sat in triage. She would be rolling up the elevator to come to us, and we would directly take her to a room and do those things. So again, I think that patient didn't get the care and support that she deserved in that situation. And then the patient who was wheeled out of the hospital without having a physician check her and give her the opportunity to see if she's actually in labor, to give her time to not feel comfortable. I personally wouldn't have a patient rolled out of the hospital who looked like that, but biases are there for people, and they might just be like, oh, she's being dramatic. And you have to really address your own bias with those things. And you really have to think about, if this was me, is this how I would want to be treated? And really center the patient in that care. But the continued discussion, I think, is so incredibly important, because no matter how hard people advocate, Black women are still dying at higher rates than white women. And that's important to acknowledge. And it goes from all parts of care, from before prenatal care to getting, family medicine involved, getting chronic medications or chronic conditions under control, getting them in for preconception counseling if you are on different medications or have different medical problems, to really optimize them prior to pregnancy. And then really see them as individual people who need individualized care in their pregnancies.
Thank you for that.
One thing we like to do when we have guests, but even with Sheila and I, is we like to leave kind of our top 3 take-home points. And we do have a lot of medical learners that listen to this show. So can you give us your kind of top 3 take-homes from this case for our medical learners that are listening?
I think number 1, if you have a laboring patient show up, that you take them to the place where they're going to have the most comprehensive team available to care for that patient. 2, if you have a shoulder dystocia, step 1 is lay the patient flat and get the legs back, right? That's going to resolve actually a lot of shoulder dystocias. And step 3 is make sure that for any emergency, you have a really good algorithm that you feel confident reciting top to bottom to take care of a patient. I think you saw in this episode, they really knew the postpartum hemorrhage algorithm, and that's a part of training. And for those emergency cases, being able to recite the algorithm flat out is really important. In residency, before every delivery I walked into, I quickly went through a shoulder dystocia, all the maneuvers, and I quickly went through the hemorrhage steps before everyone, just to remind myself, so I didn't have to think about it. I didn't have to think about what's the next step. It became so much a part of my routine. And so for anyone going into any field, knowing your high risk situations and feeling so confident in that algorithm is what's going to save your patients' lives.
And that one resonates for me as an ER doctor as well, right? Because emerge care is very algorithmic, and it almost Sheila and I have talked about this before on the show, is that you almost kind of it's just, if you know the steps confidently, it doesn't matter how terrible the case is in front of you or how devastating the case is in front of you. You just know how to act, and you know that algorithm down cold. And that's what really the best thing you can do to try to save that patient's life, is knowing those steps down.
Yeah, for sure.
100%.
One of my favorite OBs taught me, she said, obstetrics is such a beautiful field to go into because it's 99% of the time it's really beautiful, but there is that 1% of sheer terror that can come through. And being prepared in those moments, like you said, Fran, are so instrumental. The last thing that we always do is also like, are there 3 things that you would suggest to patients, like prenatal patients or people who are preparing for pregnancy or postpartum, 3 things that you would love for patients to know about having a healthy pregnancy and delivery?
I think, like I mentioned, a preconception appointment could be really vital in getting all your team involved, whether that's your family medicine doc, whether that's your psychiatrist, your therapist, your OB-GYN, really getting your health and your team together to optimize you prior to pregnancy. In the beginning parts of pregnancy, asking things like, do I qualify for a low dose aspirin? Some people are, and we have the study just came out again that docs aren't as good about recommending low dose aspirin as they should be. So asking, do I qualify for this? Typically, we started around 12 weeks, ideally before 16 weeks. So just asking, should I be taking a low dose aspirin? And then really having someone who can advocate for you. As you saw in those videos, they had their moms there with them trying, but it's better than being alone. So having an advocate with you at appointments, when you go to triage, hiring a doula. Many states now pay for doula, someone who will advocate for you if you don't have someone who can. I always joke I was my sister-in-law's kind of stand-in doula because my brother-in-law is terrible with medical stuff. So I could just be there being like, okay, no, we're going to get you your epidural. Oh, it's not working. Let's ask the anesthesiologist to come in. I was her advocate. When my brother-in-law couldn't be because he was going to faint in the corner, right? So having someone who can help you, many states, like I said, do pay for it. In New York State, doulas are available for patients with Medicaid, funded by the state, which is incredible. So having someone, so you don't feel so alone, that you don't feel like you're fighting just by yourself. Not that I obviously ever want anyone to feel like they're fighting their care team, but as we saw, that's still happening, and we have to be really realistic about that.
That's so great. What a great way to leave off. Thank you so much for joining us with this case. It was so great to have this conversation with you. And I mean, I'm so glad that we were able to talk to us because I learned a lot even just being able to have this discussion with you too. So thanks so much.
Yeah, thank you so much for this opportunity. Happy to discuss obstetrics and gynecology anytime.
That's amazing. And if you're not already following her, please go check out at Paging Dr. Fran on Instagram and TikTok. She is one of the best educators out there. So we are very grateful for you taking the time out of your busy schedule to be here with us today, Fran.
Of course. Thank you.
So it's so great to have Dr. Fran on and give us her perspective on that case. It was so wonderful to hear her thoughts. But let's get back into episode 10 and 11 and go through sort of what we're seeing. And the first thing was sort of the fallout from Dr. McKay calling the police about David and Robbie's reaction to that. Now, what was really interesting, we got a chance to talk to Fiona Dourif, who plays Dr. McKay. So please tune in to episode 8 and 9 recap because she was so phenomenal and clearly a badass in real life, but also a badass on the screen.
Yeah, after talking to her, I actually have so much more perspective on the cases that she's involved in. So please do take a listen to that episode. It was an awesome conversation. Now, with this case, I love how she stood her ground with Robbie. For me, this is the moment in the season where Robbie's reaction actually really disappointed me. He really was focusing on the idea of ruining a young man's life versus the safety of who knows how many girls that were on that list. And for me, that comparison didn't land. And it really just perpetuated this, the patriarchy of society that we live in and how we continue to have this inequitable treatment of men versus women. And I have to say that was a very it was a point of disappointment for me in Robbie's character.
Yeah. And we'll see as the season goes on, more nuanced discussions around this and really well handled overall. And I think, we'll get into it later on a bit more. So the next case that was really huge and impactful was the burn case. So full body burns, hoarse voice, his nasal hairs are singed, which was a nice point to point out as well. These were all red flags that his airway is compromised.
So I love this because this is an oral exam case. And so this is where I can tell that there was an emergency doctor that was consulting on this case because it's what are the indications of an intubation in someone who has burns? And they listed every single thing off. And that's what this patient has. And so this was this part was extremely accurate because that's exactly what you would say in an oral exam case. And that's exactly what the textbook says and exactly what you would do in real life as well. So the hoarse voice, those singed nasal hairs, the thought process behind this is that it indicates that there's an airway burn. Like these are all indirect signs of an airway burn. And when there is burns, there is swelling. And the airway is not something that you would want swelling in because that's when it becomes compromised. And so if you see these signs, the idea is that you would put a breathing tube in before that swelling starts when it's still easy to do it versus when it would be very challenging to do it.
And they also mentioned, Chaz, I was going to ask you, the Parkland formula. So what is that?
Yeah, so I also love this as well because this is, again, exactly what we do in medicine. So the Parkland formula is a formula that you use where you calculate the percent body surface area of burns that a patient has and their weight, and then you give an amount of fluid based on those two parameters. And that is the intention is to replace the fluid losses that a burn patient has with these burns because when you damage that skin barrier, you can become dehydrated because you're losing all this fluid very quickly. And so it's very important to like resuscitate them with fluids, but then also really replace those ongoing fluid losses. And that's what the Parkland formula does.
Burns are so devastating. Like that was such a powerful case. It was also a nice moment for Whitaker to really connect with the wife of the patient. Really beautiful interplay there and conversations that happened and was like a really lovely moment.
And the thing that stood out to me there also, not only the interaction with Whitaker and the patient's wife, was that last interaction with Langdon and Whitaker, where he really just like, really without showing a lot of compassion, is just like, yep, this guy's going to have a bad outcome, which is true. So burns of this severity really do have a very poor prognosis because the risk of infection and sepsis is just so high. And so Langdon is correct, but the way in which he just had that discussion with this like impressionable medical student really lacked the kind of grace and compassion that I would have expected from a senior medical learner.
Yeah, I agree. The next case that we see is a stroke case, and in a 20-year-old. So that was really shocking. I think when we think about stroke, we think about older individuals. I've actually unfortunately seen this in practice, and it can be really devastating.
And even Mohan is like, who gets a stroke in their 20s?
Yeah.
And I mean, the answer is like, people do. And in this case, we find that it's because of a carotid artery dissection. And what that means is that there is basically a split in the artery, in the carotid artery. And that artery is one of the main ones that supplies blood to the brain. And if there's like a break or a split in the kind of the lining of that artery, it causes an obstruction. The blood can't get through. And that's effectively what a stroke is, right? It's not enough blood and oxygen to a part of the brain. And so that's what we see here with this patient.
So let's get into a quick teaching corner here, Shaz, on stroke basics.
So when it comes to stroke, rapid assessment is everything because time is brain. We've talked about how time is muscle.
Brain.
Yep. We've talked about how time is muscle with our heart attack cases.
Time is testicle.
Brain. Time is testicle with our torsion cases. So we love these kind of things in medicine. Yeah. In this situation, time is brain. And so what we need to know very quickly is if they are having stroke symptoms. So that can include things like their speech is not appropriate, whether they're confused or they're slurring their speech. They have a facial droop. They have weakness on one side of the body. Those are big signs of a large territory stroke. And as soon as those are identified, we have to get them to the CT scanner very quickly because what is important to know is whether the stroke is from a bleed into the brain, so like a ruptured blood vessel, or a blocked blood vessel to the brain. And those two things are treated very differently. One of the most effective drugs to give for kind of blockage type strokes or a clot buster because it breaks up that clot and allows the blood flow and oxygen to go back to the brain. But you can imagine you would not want to give a clot buster, if somebody was bleeding because it would make that bleeding worse. And so that's why that CT scan is so important to get as quickly as possible to help us get that medication if it's required into the patient as quickly as possible.
Yeah, absolutely. And, for everyone listening, if there is a concern about stroke, we just want to really quickly go over what we teach our patients to look out for symptoms or signs to look out for if you may be having a stroke or you're witnessing a loved one have a stroke. So what we do is we teach something called the FAST acronym, and these are the things to look out for. So F is for facial drooping. So yourself smile and look in the mirror if you're worried about yourself, or ask the person that you're concerned about, ask them to smile. Does one side of their face droop or does it look uneven? A of FAST is arm weakness. So raise both of your arms up or ask the person in front of you, raise both arms up. Does one arm drift downwards or are they unable to rise? And sometimes patients don't actually know that they aren't able to do this. Like they're not aware of this symptom happening or the droop happening. So F, facial drooping. A, arm weakness. S is for speech difficulty. ask them to say something simple. Is their speech slurred? Does it sound strange, or is it difficult to understand? That could be a sign of a stroke. And finally, if you're having any of these symptoms, T is for time. So it's time to call 911. If you're having any of these symptoms, call 911 immediately, because this is when, and note the time that the symptoms appeared, because it goes back to your point, Chaz, that we need to know how long you've been having symptoms to be able to direct the kind of treatment that we have time to be able to give you.
And if you want a deeper dive into this topic and other issues related to heart and brain health, check out episode 10 of the Doc Talk from season 1, where we do a much more detailed dive into stroke and other forms of heart disease.
Awesome. The next case, Chaz, was about the eye trauma, like the baseball player who comes in after getting a baseball right in the eye. And that was wild. Like the blood collecting behind the eye, causing this high pressure situation that was very dangerous for his vision.
Yeah, so this is what is called a retrobulbar hematoma. So retro means behind, bulbar means the eye, hematoma means blood. So it's like blood that kind of collects behind the eye and basically can push the eye forward. And that the issue with that is that the optic nerve, so the nerve that kind of is what's causing you to be able to see and send that information to the brain, it gets tugged, right? You can imagine if the eyeball is being pushed out, that optic nerve has a bunch of like stretch and tension on it. And if that happens for too long, it can actually not function properly anymore, and it can lead to permanent blindness in that eye. And so this is where the procedure, which they did called a lateral canthotomy, where they cut the side of the eye, and there's like these two tendons that are basically holding the eyeball in place and not allowing it to push past any further. And so when you cut those ligaments, sorry, not tendons, when you cut those ligaments, it basically allows that pressure to be relieved outward. The eye can move out even more so, and then that pressure gets relieved on that optic nerve, and that tension gets relieved on that optic nerve. And so they do this procedure. I mean, like the procedural part of it is perfect. Fiona told us a couple weeks ago, they did this 2-week boot camp. And I wonder if this is one of the procedures that they did in that boot camp as actors. But the question that stands out in my mind is like, what procedures are they going to have left for season 2? Because they've done so many rare procedures in season 1. Like these are things that we see a couple times a year. They've done like all of them in one episode. So I'm really, really excited to see what they have in store for season 2 and what other rare procedures and rare cases they come up with.
So one of the nice things about these episodes is that we also learn a lot more about the characters and what their special sauce is, which is the term that they use. And so we learn a lot about Javati, the medical student. She started college at age 13. She has a strained relationship with her parents, in particular her mom, who works at the same hospital. And then we see this like in-depth conversation between Malhan and King talking about what their special sauce is and like really emphasizing that we each have that little thing that makes us special and how we interact with our patients. So like, Chaz, I'd love to hear what yours is.
Yeah, I love this interaction too, because it's like not something that we think about very often, but Mohan is spot on, right? That everybody has something. And just because we don't put a name to it or are able to articulate it doesn't mean that we don't have that, because everybody has this different approach to medicine and brings a special kind of lens to it. For me, I think it is, and I think being a mom also helps this as well. It's being able to be present and command a room, like a resuscitation room or a trauma, and staying calm but firm and assertive even when the room is completely chaotic. And so having that ability to have everyone know who's in charge, where you're positioning yourself in the room, but also having everyone look to you even in the chaos to ask what's next or on what to do. I think that I do a pretty good job at that.
No, I'm sure. I think you're amazing at that.
And what about you? What do you think your special sauce is?
You know, I've been starting to ask my residents what their special sauce is. And I've loved hearing their take because it's really fun to kind of think about that and reflect in a different way. For me, you know, I think the healthcare system isn't always a safe place for many of our patients. And what I love to do is make these spaces safer. And so making them comfortable, feel heard, validated, understanding that saying something or intervening isn't always therapeutic in situations. Sometimes just holding space is important. So I just love sort of what I do and making people feel safe to share their most vulnerable moments. And it's something that I really honor.
I love that. And, you know, I feel that with you too, even just in our friendship. So I can see how that applies to your patient care too. So nice. I love it.
So we're going to get right into something that I think you and I both felt very deeply in our core, which was the scenes that happened around violence against healthcare workers. Mm-hmm. And Dana coming in after being punched in this episode was sort of when she said, like, it happens all the time. Like, that hit so hard.
Yeah, and this is something that I've been like reflecting on a lot because it's not only like, so she came in and she was kind of trying to brush it off initially. And then the hospital administrator, Gloria, comes down and she's like, right. And then like, just as Robbie's kind of starting to have a conversation with the nursing team about this, and like, they're like, this happens all the time. This is like, we don't feel safe here. What are you going to do about it? And then Gloria comes down and she tries to kind of just like, not give it the time and seriousness that it deserves. And the nurses just eat her alive. And I'm glad to see that because I think it's a really important conversation that like the kind of issue of violence in the ER is a real issue. Every emerge doc and nurse that I've known has been assaulted in some way, shape, or form. And like the problem is that like we know it's not acceptable. We're not talking about it enough because we don't get to see how common this is because we're not having these conversations. And for me, I think the important point in this show, in this episode, is that the show didn't sensationalize it, but they like normalize it and they really brought to light just like how big and common of a problem this is.
Yeah, they listed off the stats like right there. Those were real stats that they were listing off about violence against healthcare workers. And I thought it was so powerful because it really was like, we're not going to look away from this right now. We want everyone who's watching to understand this and acknowledge it. So it was really, really an excellent moment for the show because as you said, unfortunately, this is very real. So episode 10 ends with a really big moment.
Yes, big moment. And it's been building. Moment. It's been building towards this moment.
Like Santos and Langdon do not like each other. Langdon don't like each other. And this is the moment where Santos shows Robbie the vial of lorazepam. So the benzodiazepine, like this is when it gets all revealed. And he confronts Langdon. And that moment where he opens the locker is absolutely gutting.
And you can see how upset and torn up he is about this just in the acting, the way his face looks. Like you can see it, like it is literally heartbreaking to him to see like what I think is his protege, right? Like that is how they've built this up, that Langdon is like the star resident. Robbie talks about like recommending him for an award earlier in the season. Like this is someone that like Robbie has put a lot of faith and trust into and like really believes in. And then to see that it all come crashing down by finding these pills in his locker and then just like not backing down, getting him out of there and like having the episode end that way was huge for sure.
And then they pick up right away in episode 11 at the beginning. You know, Robbie's about to flush the pills down the toilet. Like Langdon's left at this point because Robbie's told him to leave, but he keeps them. He keeps the pills.
Yeah, and that ambiguity was kind of interesting and I think probably intentional because like what you kind of wonder, like, is he flushing them because he's scared he might use them because you can see the stress of like stress building on him in this season, in this shift. Is he thinking about flushing them because he wants to try to like not get Langdon in trouble and try to like figure out a way to brush this over? Like it remains ambiguous because he just puts them back in his pocket and then carries on with the rest of his shift. So from here, the next case we see was kind of weaved in with Mohan kind of working on this patient case with Whitaker, where they have a patient that has like the classic signs of opioid withdrawal. So he has like Whitaker lists these off, but like the sweating, the abdominal cramping, the pain, the nausea, the diarrhea, and the piloerection, which is goosebumps. That's like a medical name for goosebumps. And I have to say that I really did not like Mohan's approach here. There was very little compassion. Like it was just kind of like very robotic. There was very little compassion and a significant lack of transparency in how she was managing this patient's symptoms. And she kind of like even was teaching Whitaker that, let's just use bupe, or like, which is a treatment for opioid withdrawal. Let's just use this. And if his symptoms go away, then we know that he's lying about his drug use. I didn't like that at all. Like super not appropriate.
Yeah, it was kind of off character for her, right? Because she's generally such an empathetic character. And so that was interesting because we know that addiction is a chronic medical condition. And so the framing of this was really important and she missed the mark on it.
She did. And I do have to say, like, this is where Robbie really redeems himself with this patient because he immediately recognizes and calls out that what Mohan has done is inappropriate and then goes into the room and very directly and transparently communicates with the patient and even says like anybody can be an addict. You are proof of that, which is 1000% true.
So this case gives us a good teaching moment on buprenorphine that we mentioned, the medication that Mohan has given and when we use it. So let's get into that.
Yeah, so in terms of opioid use disorder and buprenorphine, it's like a relatively newer agent that we use in practice.
And it's a partial opioid agonist, so it prevents withdrawal. I actually had a patient a few weeks ago who we initiated this medication on in family practice, and it's going really well so far. So it's one of these new tools that we have available to us. So I think often when we think about opioid use disorder, we think about methadone, but this is a different agent, and it's really, it can be quite effective.
Yeah, and we actually do buprenorphine starts in the ER a lot
Oh,
as
amazing.
well. Yeah, because of just the patient population that we serve in the inner city hospital that I'm in. And when patients come in with opioid withdrawal, we have like very open, transparent, and informed conversations with them about whether they want to start this. I mean, the great thing about buprenorphine is that it's much safer than methadone, less kind of cardiac side effects, and it's one of the best tools that we have for opioid use disorder.
Okay, Shaz, so the end of this episode is, we're coming up to Pitt Fest with the active shooter, and it's a total cliffhanger in that moment.
So that last scene with like Dana and Robbie just going outside, having a little breather, and like really getting into a deep conversation, like Dana saying, I don't think I can do this anymore. I don't think I can do Emerge anymore. And then all of a sudden her phone rings. Robbie gets an alert on his phone, on his cell phone as well. And she looks at him and she says, there's an active shooter at Pitt Fest. And then the episode is over. And so this is what's going to set us up for like the next episodes. But like what a cliffhanger to hang, like to leave us on for this episode.
And we've been hearing about Pitt Fest as well, because we know that Jake is there. We know Robbie's
that Jake
stepson is there. We know, like, it's been talked about. It's been foreshadowed already. So that was a moment just to end on. So before we end our episode, let's end as we always do, like our favorite moments from these episodes, Shaz. So what was your favorite line of the week?
The line of the week that really stood out with me was that line that Dr. Robbie said to the patient opioid withdrawal. Anybody can be an addict. You are proof of that. What about you, Sheila? Who's your MVP?
So I know Santos hasn't been our favorite necessarily because she has a bit of overconfidence, but that took a lot of courage for her to step up, speak to Robbie, and disclose concern about what Langdon was doing. And so I felt like she was my MVP. What about yours, Shaz?
Yeah, for me, I think like McKay really stood out to me because of how she stood her ground with calling the police on David, even though Robbie was completely against it. Like this one really stood out to me. So she's my MVP for this week.
And what was your most relatable moment as an Emerge doc, Shaz?
So there's like a point where Robbie says, there's only 1 hour left in this shift. And like the implication is there's only 1 hour. What could go wrong? You never say those things. It's like saying the Q word. You don't say quiet either. And so when he said that, I'm like, oh, there's going to be chaos. And then and how does the episode end? There's an active shooter at Pitt Fest. So you know that things are about to get chaotic. So I feel like he like totally summoned the drama by saying that.
It's amazing how Emerge docs like are so superstitious about this stuff, because you're like, oh, okay,
we are.
I said it, now it's going to happen.
Yeah, totally. Okay, so let's dive into our take-home points for our medical learners. Here are the top 3 things we want you to take home from these episodes.
So number 1, you know that stroke can happen in young people. And if it does happen, think about carotid dissection.
Number 2, retrobulbar hematomas are an emergency and can be vision threatening. So if you see a patient that has high eye pressure after trauma, proptosis, so their eye is sticking out and they have vision loss, the most appropriate treatment is a lateral canthotomy, and that can save a life. So get ophthalmology or your emergency department attending involved very, very quickly.
And number 3, postpartum hemorrhage can be life-threatening. So you need to move fast and follow the cascade. You got to massage, you got to do the oxytocin, misoprostol, TXA, and you may need blood. And I've seen this happen. We need to act really quickly because, again, it can be life-threatening. So these 2 episodes were super intense, emotional, and honestly, you know, I feel like we say that every time we end one of our recaps, Shaz, is like intense, emotional, but really, honestly, so close to life for a lot of our Emerge colleagues and also specialty colleagues.
And next week, we head right into the fallout of the cliffhanger of episode 11 for episodes 12 and 13, which take us right into the most realistic MASH casualty depictions that TV has ever done.
And as always, please do send us your questions about the medicine, the storytelling, or the behind-the-scenes choices that were made, because we'd love to answer them and pick your brain, Shaz, right, as to what's real and what may be a little bit of an exaggeration.
Absolutely. We'll see you in 2 weeks.
A quick reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. And be sure to follow us on social media at the Doc Talk Pod. We'd love to hear from you. Please rate and review. It helps us elevate the podcast and reach more listeners.